Hi, this is Ed O'Brien. My evidence-based practice presentation is on radiation dermatitis. Approximately two-thirds of patients diagnosed with cancer will receive radiation therapy. Up to 90% of those patients treated will experience an adverse skin reaction, making radiation dermatitis the most common adverse effect experienced by patients receiving radiation therapy. Symptoms range from mild, like erythema, to severe, like tissue necrosis. Radiation dermatitis can affect quality of life for cancer patients, lead to added treatment expense, and can prompt early termination of treatment, which can ultimately affect outcomes. Prevention and treatment of radiation dermatitis remains elusive. There is currently no standard of care for treating radiation dermatitis. Studies looking at reduction and/or delay in symptoms with a variety of treatments have been performed, but are generally small, lack a control group, or only compare the agent with placebo, not another agent. The purpose of this presentation is to review recent literature concerning the treatment of radiation dermatitis and determine best practice for patient-centered care. My PICO question is, in cancer patients with radiation dermatitis, is it one topical treatment cream or oral agent superior to others in symptom reduction? A literature search was performed using the Pennsylvania College of Health Sciences online library using the Senile Research Database. Full-text, peer-reviewed articles published in the last 5 years in the English language were sought using the keywords radiation, dermatitis for skin, and treatment. Related words and equivalent subjects were applied in order to produce adequate search results. The articles chosen were selected based on study design and content. The first article was a pilot study using a prospective, randomized, controlled trial that compared 3 topical agents: a homeopathic cream, a candula, a hydrogel cream, and a steroid cream combined with an emollient cream. The authors wanted to compare the agents in terms of grade of radiation dermatitis experienced by the patients, effect on the quality of life during treatment, and treatment costs. The subjects were a homogeneous group of breast cancer patients receiving radiation therapy. There were only 30 subjects enrolled, but they were equally distributed among the treatment teams. The authors did not find any statistically significant differences among the creams in regard to severity of radiation dermatitis or changes in the quality of life. But they did note a significant cost difference, with the candula cream being lower in cost than the other two. This pilot study could prove beneficial if implemented on a larger scale as a double-blind, randomized, controlled study in multiple centers. In the second study, the authors sought to evaluate the effectiveness of oral prophylactic treatment with Adlai bran extract in reducing the risk of severe acute radiation dermatitis. Adlai bran extract is a cereal crop previously shown to have anti-inflammatory and antioxidant properties. The authors used a prospective, randomized, double-blind controlled study design. They used convenience sampling and selected consecutive female patients with unilateral breast cancer presenting for radiation therapy who met inclusion criteria. Of the 110 patients enrolled in the study, 73 received treatment with oral Adlai bran extract, and the other 37 patients received placebo with olive oil. Patients were randomized in a 2-to-1 ratio using a computer-generated list. Treatment with drug or placebo started with the beginning of radiation therapy and continued through the duration of treatment. Patients took 2 pills twice daily and were monitored for compliance. Patient skin was evaluated by a radiation oncologist and dermatologist jointly at the beginning of treatment and again at the end of treatment. Both physicians were blinded to the treatment group. A score was given to the skin reaction based on consensus using the radiation therapy oncology group scoring system. Skin reactions were classified by grade from none to severe. This study suggests treatment with oral Adlai bran extract reduced the occurrence of severe acute radiation dermatitis, grade 2 or higher, in breast cancer patients compared to placebo. The study also found that higher BMI was associated with the development of radiation dermatitis. The use of oral Adelaide bran extract may be useful in the prevention of severe acute radiation dermatitis for patients receiving radiation therapy. Additional trials with more patients would be necessary to help determine treatment parameters. A larger sampler size would have improved the strength of these findings. The purpose of the third study was to investigate efficiency, safety, and tolerability of Zonred, a topical agent in preventing radiation dermatitis associated with head and neck cancer radiotherapy. Using convenience sampling, 41 consecutive patients meeting inclusion criteria were enrolled in a monocentric prospective pilot study. Subjects were at least 18 years of age, had head and neck cancer, were suggested to receive radiation therapy, and did not meet any study exclusion criteria. The topical gel was applied twice daily to irradiated areas during radiation treatment and was continued for 2 weeks following completion of treatment, or until grade 3 toxicity occurred, at which point Zonred was discontinued. Patients were evaluated at baseline, weekly during radiation therapy, and 2 weeks after completing treatment by the same 2 research radiation oncologists. Both physician assessment of skin toxicity and patient-reported outcomes were used to determine how well the product was tolerated and if it was effective in delaying and/or reducing radiation dermatitis in this patient population. The authors compared study data to historical data. Compared to the historical group, the study group had a lower incidence of grade 3 skin toxicity and delay in the onset of grade 2 skin toxicity. The study suggests that the topical gel Zonred is safe and effective in reducing and delaying high-grade radiation dermatitis in patients with head and neck cancers, but a larger study with a randomized control design would be helpful for establishing true efficiency. In addition, this study was limited by the use of historical group for comparison. The historical group received a higher dose of radiation therapy than the study group. The authors of the fourth study wanted to look at skin toxicities over time in a randomized study of mometasone versus placebo during breast radiotherapy. The authors used convenience sampling and enrolled patients with breast cancer presenting for radiation therapy who met inclusion criteria. 176 subjects were enrolled. This was a multi-center study conducted by the North Central Cancer Treatment Group at the Mayo Clinic in Rochester, Minnesota. Using a 2-arm, double-blind, randomized study design, breast cancer patients having radiation therapy were randomized to mometasone topical cream or placebo cream. Skin toxicity was assessed weekly using both physician-reported and patient-reported outcomes. Using a provider-reported survey as well as a patient-reported outcome survey, data was obtained at baseline and weekly during radiation therapy regarding symptoms of radiation dermatitis. The authors found that by the provider reporting surveys, significant differences favoring mometasone were detected over time in all toxicities except skin striae, atrophy, and infection. This study suggests that mometasone reduces acute skin toxicities and symptoms of radiation dermatitis compared to placebo. The author also suggests that patient-reported outcomes, as opposed to provider-reported outcomes, may provide a more comprehensive range of symptoms and experiences. The last study was performed to look at the efficiency and safety of a traditional Korean medicinal ointment in preventing radiation dermatitis. Jeongo is commonly used for treating skin wounds like burns, cuts, abrasions, and frostbite. Using a prospective single-blinded design, the authors performed a pilot study with a primary endpoint of incidence of radiation dermatitis and secondary endpoints of timing of onset and duration of the dermatitis, as well as pain level. 30 patients with unilateral breast cancer scheduled for radiation therapy and meeting inclusion criteria were enrolled. Patients were randomly assigned to receive Jeongo as the intervention group or general supportive skin care as the control group. 29 patients completed treatment. The authors found that Durango reduced the incidence of grade 2 or higher radiation dermatitis and also delayed the onset of grade 2 dermatitis. The authors concluded that Durango minimized radiation dermatitis in patients with breast cancer without causing adverse effects. A larger sample would have improved the strength of this study. All the literature reviewed was from prospective quantitative studies using experimental designs. 4 out of 5 studies were performed at single centers and all utilized relatively small sample sizes, with 2 of them being pilot studies. Overall, for radiation dermatitis treatment, whether with a topical or oral agent, was superior to placebo. And in one study, no topical agent was inferior to the others in regards to treatment. A few of the studies also suggest that subjective data from patient surveys should be incorporated with provider-based assessment of patients with radiation dermatitis. Although no conclusive evidence exists, current literature suggests that certain topical agents like mometasone and Zonrid may be more effective than placebo in delaying the onset and reducing the severity of radiation dermatitis. Natural products with anti-inflammatory and or wound-healing properties, like Durango or calendula cream, could prevent or minimize radiation dermatitis. Oral agents with anti-inflammatory properties, like Adelaide bran extract, should be considered for minimizing symptoms of radiation dermatitis. Patient-reported outcomes surveys should be considered for incorporation into objective assessments of radiation dermatitis to improve patient care. There is a need to perform large, multi-centered, double-blind, randomized clinical trials comparing topical and oral agents in order to determine best practice for the prevention and treatment of radiation dermatitis. This can be very time-consuming and resource-intensive. It may also be difficult to recruit and enroll large groups of homogeneous cancer patients needing radiation therapy in order to provide a good sample for comparing treatment to placebo or one treatment to another. Also, using consistent methods for skin assessments with good inter-rater reliability may be difficult if the studies are performed at multiple centers or by multiple investigators. Prevention and treatment of radiation dermatitis remains a challenge. As we wait for larger clinical trials to produce evidence for improving patient care related to radiation dermatitis, we should continue to evaluate the care we are providing and use both expert opinion and the current literature available to promote the best care we can for our patients. These are the references I used for this presentation. Thanks for listening to my presentation.